just a few more questions related to checkpoint inhibitors. One is there a patient which you would not offer this drug to? And who is he or she? Is it a patient with an autoimmune disorder? Is it a patient who's on steroids for other reasons? Is there a clinical scenario where this does not become the de facto second-line regimen for a squamous cell patient? Ed?
Yeah, I think the two you mentioned, generally we're guided by the clinical trial and what exclusions there were. We will learn over time how exclusive they were, if they were over-exclusive or not. But, and even the steroid aspect, you know, we talk about physiologic doses versus non. But I think just as big messages, you want to avoid people who are on chronic steroids as well as those who have autoimmune disorders and the never smokers. I think it should be equally in there. That was not an exclusion criteria, but I think it should be in there as well.
Yeah. I think that's absolutely right. I think the other thing to call attention to is that while overall it was much better tolerated, and they are much better tolerated than docetaxel, there is that small single-digit frequency of grade greater than or equals to 3 autoimmune events, which can be quite severe and can come out of nowhere if you don't, if you're not observant of these things early on. So that's the other thing, is that, you know, we need to be diligent. Providers as well as the patients need to help us with this, to call out anything that might be brewing, so we really can keep an eye on it.
Yeah, the AE profile of these drugs, I think, has forced us to work with our other colleagues from other disciplines. And, you know, the pneumonitis and the colitis, the hepatitis, the endocrinopathies, those AEs are on the low end, but they're there. Have you guys seen these? And if so, how do you manage those? Are you employing the expertise of a pulmonologist or a gastroenterologist to help you managing them on your own? How are you doing this?
So we have. We were, I'm sure as all of you were involved in the early phase trials for this. And so we've seen not a high frequency, but still a number of cases of pneumonitis, colitis, hepatitis, encephalitis, you know, any itis that you might imagine. And it can be difficult because the reflex is to start very high dose steroid, stop drug. But what do you do if that doesn't work? And then you're relying on your colleagues in hepatology, also in rheumatology, for adding anti-TNF alpha agents on top of that, for T-cell suppressors like cyclosporin, and then you really are in the weeds in terms of what you're doing, and in terms of the long-term consequences of that degree of immunosuppression also. So it's one of those things where most people will not get to that point, but you know, if there's a sense that your patient is getting to that point, then getting all that help, you know, for specialists and consultants to help you try to manage them and to get the patients over it.
Well, I think one of the biggest struggles is actually more on the front line. If your patient's seeing you in clinic, then you can refer them to the specialist. They're going to go to the emergency room or the urgent care clinic after hours, and they're going to get Imodium. And that is a problem.
Right.
And so what we've done is we have posted immunotherapy side effect management pathways up so that, and we've also educated the patient very strictly to say, hey, before you touch me, I am on an immunotherapy agent. And so that triggers that provider, whether it's an ACP that's seeing them, whether it's a clinician, to look at that pathway and then follow that pathway, the colitis pathway, the pneumonitis pathway, the LFT pathway, any of the hepatitis, UVIs, all of those things we have listed on an electronic format.
And we do the same thing. We educate. We have a packet that we give to patients in a card just so that they're aware and their other care providers are aware that they're on an immunotherapy drug. I agree. Patient walks into the ER and says, I'm on some chemotherapy and have diarrhea. They may be getting Imodium, not realizing that this is a colitis. Although these AEs are a little bit on the lower end, they do happen, and we have seen them. So I think that's an important point. The other thing that I want to get to with the immunotherapy drugs is just this concept of pseudoprogression and how this is now factored into immune-related response criteria. And I won't get too granular, but immune-related response criteria was a criteria put forth by Jed Wolchuk in the melanoma group a few years back, and we try to carry it over. And it does factor in the potential for pseudoprogression and not calling these patients technically progressive disease. Have you guys seen pseudoprogression? How do you manage it? How do you manage this? Do you confirm it with a scan 4 to 6 weeks later? Is this something relevant? I think if you look at at least the melanoma data, their rate of pseudoprogression is on the low end, 5%. Experiences?
It goes back to what I tell patients, no matter what therapy I'm giving them. Because you'll commonly see scans where tumors look a little bigger than from 8 weeks, 6 weeks ago, and the radiologist has read it as definite growth because it is. They're black and white, and they see it is bigger or smaller. I think it's important, and what I tell them is, look, if the scans look bad and you're looking bad, we got to do something different here.
Right.
If the scans are bad and you're looking good, there's a disconnect here. And the exact opposite say. If the scans look good and they look bad, something's going on. And if the scans look good and they look good, that's the best case scenario. Right. So it's that sort of gradient between the best case scenario and the worst case scenario. And the two in the middle, I think we have to not take patients off quickly due to a scan report when they look great in front of you. I'm tolerating the drug, I didn't have any side effects, I went skiing last weekend, or continue them on a therapy just because the scan shows. So I think modified immune resist is kind of just a clinical judgment characterized in writing.
Right.
That's right.
And then it speaks again to what you've spoken about before, what you've alluded to before, which is personalized and individualized, and really getting as much information as you can from the patient. I agree. We have had plenty of patients in which we've seen some growth, and maybe it's not even pseudoprogression, and they're doing great. And there's weight gain, and there's pain relief. I've kept them on. And I think that we have to have that sort of individualized approach. Paul, your experience with pseudoprogression?
Well, I agree with all of this. Part of the problem with pseudoprogression is that we invoke it, patients know about it, and you sort of, if a patient, the question is, well, how far do you sort of follow this through? Do you wait a little bit longer, wait a little bit longer? For me, one of the things that I've seen, at least for my patients with pseudoprogression, that can help is that the kinetics sometimes are different. You have the natural history before you start, and for some of the patients I've had who had pseudoprogression, the kinetics just changed. The growth rate seems to be faster in a relatively short period of time than what we saw in the natural history. For me, this can help tease apart whether or not that might be pseudoprogression, because it would be unusual for the natural history just to change from starting a new therapeutic in the bad direction. Right. I mean, that can be challenging though, because these patients can also be sicker. So it's not like you can continue the drug because they're getting sicker. It just means you sort of have to wait it out and see what happens on a subsequent scan. And there are some patients, again, who have had this change in kinetics who on subsequent scan, we get them through it. It really is a response. It's a nice response that they end up seeing. But it's exactly as it had said. Because of that, it really needs to be personalized, right, for any given patient. It's going to be a low frequency, but you can't take it away prematurely, and you can't keep them on it for too long and risk, I think, not giving them something that's going to be effective.
One of the things I do for my patients, and I'm bringing the cup into the photo, by the way. We'll make sure we don't have any.
We love visuals.
Is that I'll hold something like this up to them, and I'll say, well, if this is where they measured your tumor, and then the next time the cut was through here, that's a response.
That's right. Yeah.
If they cut it here the next time, that's progression.
That's absolutely right.
We don't weigh tumors,
Yeah.
right? And that's the way we would know if something's actually growing or not. Just by two-dimensional measurements is not really good. So
yeah, RECIST is maybe not the best way to understand whether a patient is truly garnering a benefit or not. Let's move on to...